Some time when I was living in Florida working outside of the hospital. I worked at a medical daycare for medically fragile children. It was a pediatric prescribed extended care center. So this was for kids who couldn't go to a mainstream daycare because they just didn't have the training to care for kids, like kids who might have cystic fibrosis. So I did take care of one. As an infant, that I got to know him really well, he took his first steps with me, like that day. It was like, so we bonded. So this is why I'm excited about this day. RSV is all I ever do. Cystic fibrosis makes me think of my little friend. And I moved before he ended up going off to elementary school, but we spent a lot of time together. So there's a place in my heart for this. I've also taken care of some adults. I think really more with clinical students. I remember at OU they get they have a population of adults that are often admitted over there. And I have a personal friend with cystic fibrosis who's an adult, and she is an anomaly, and I'll tell you why in a minute. So, anybody familiar with cystic fibrosis or know anybody? Maybe? A few people? You know somebody? Yeah? Okay. All right. So, this is a busy slide right here, but it's just a graphic to show you like all the areas that cystic fibrosis can cause problems for somebody. So what is it really? This is a genetic disorder. And then there's a mutation on the CTFR gene, and we'll talk about that in a minute. And it has an effect on the lungs and the pancreas. It's put in with our pediatric respiratory presentation or lecture theory day, but it's not really a respiratory disease. It affects the lungs the worst and the most often. Okay. So we put it with that because it appears to be a respiratory disease, but it's not. It's a whole body disease. It's also a GI disorder. So with this mutation, what's happening, and I think I probably have a slide that's going to get into it. Oh yeah, I do. I have a slide that's going to get into it a little bit more. There's a mutation on the cystic fibrosis transferase. Oh gosh, if I can remember. It's not even in here. Basically it's the chloride channel gene, the gene that allows transport of chloride through its own little pathway. Right? There's sodium pathways, there's chloride pathways when it comes to cells and electrolyte transport. And so this is a very busy slide. Please don't panic. I'll go back. I just thought that the definition was in there, but it's the CTFR gene, and there's a portion of it that's missing, and what's happening is it puts a defect in how chloride is transported. So it basically doesn't get transported where we have chloride. So who's best friends with chloride? Sodium. And who's best friends with sodium? Water. So we've got issues with sodium chloride, and salt. Okay, so we're going to get into that. But also what's happening is this is primarily an issue where we produce mucus in our body. Okay? We have mucosal lining in our lungs. We have mucus in our pancreas that helps us with our pancreatic digestive enzymes. There's another big area where cystic fibrosis gives us problems. Let's see, reproductive organs too. People with cystic fibrosis usually have difficulty with reproduction, cervical mucus, and mucus with the vas deferens and transport of sperm. So they usually have fertility issues. And then some of these other locations, so there is an effect on the liver as well, and our gallbladder, a lot of gallstones back up there because of buildup of mucus. It also affects our skin and in our sweat glands, where our sodium chloride escapes in our sweat. So it's normal for us to have salty sweat, but this is exponential because there's more chloride that's left to exit out those sweat glands, and then the sodium's going to follow with it, making it extra salty. Other areas usually are kind of a secondary problem that results from the complications that these mucus plugs in all these areas are causing, and the nutritional deficit that we have from it. Think of your mucosal lining in your digestive tract too. All right, so the malabsorption, we talked about that a couple weeks ago. So kind of like how we're ordering some of our presentations. So we talked about GI and absorption, and now we're getting into a disease that really affects that. Okay, so you can see how everything just is, it's a cascade effect. all stemming from just an issue with chloride transport. Causes all these dominoes to fall. So this isn't for you to memorize. It's really just kind of a good table to look at to help you understand the pathophysiology that's happening with the gene defect and the exocrine function of that chloride, and how we have salt loss and sweat, salt depletion, dehydration, hypochloremic alkalosis. You all hate that stuff, right? Malabsorption, diabetes, portal hypertension, so you can see how it affects that hepatobiliary ducts. The effects in the lungs. So once you break it down, it's really not that scary looking of a chart. It just kind of helps you look at all the effects, all stemming from that one little piece, right? Reproductive and intestinal. So we have this meconium or mucofecal masses, neonatal gut obstruction. What's that? Meconium ileus. Close. You guys are coming off of OB, so I'm going to pull those out. So there is overlap. Okay. I don't let you forget your previous classes. Meconium ileus can happen with these, and oftentimes that's the first sign of somebody who's suspected of cystic fibrosis, unless they did some of the prenatal testing because of family history or other reasons. We can do genetic testing before birth of a child. But if testing wasn't done because we didn't suspect it or whatever, or maybe the mom's like, yeah, I don't need to do the testing, we'll just figure out what's going on when the child arrives, and if we need to attack things then, we will. So they tend to lack that first meconium. They end up with an ileus, so it's an obstruction, because it gets so super thick, right? So constipation, ileus, those kind of issues are prominent with them. But this slide is going to show you how this happens genetically. This autosomal recessive trait. So mom and dad both have to have the trait. They don't have to have the disease, but they carry the trait. And for their children, it means 25% chance that the child will have active disease. So 50% chance they carry, 25% they have it, 25% they don't carry it, they don't have it. This is a little good graphic trying to give you an idea how the gene splitting works and how they end up with it. Most are diagnosed by age 2. It is more common in European white populations. So this is just to show you how the diagnosis it happens with the screening, lab testing. Basically, it's a sweat chloride test. So there's medication that's placed on the skin, some electrodes that help induce sweating with that medication that's then collected on that filter paper, and that's sent to the lab, and they test it for chloride to see how much is on there, or sodium and chloride. We can do, of course, I mentioned the genetic testing, carrier screening, prenatal planning, so they'll test mom and see if mom's a carrier. We can do amniocentesis, and that can tell us if the baby carrier, and then the newborn screening. Let's see. Later, we've got pulmonary function tests, chest x-rays, abdominal x-rays, and some labs too. So fat soluble vitamins are an issue in absorption, because if we have mucus in the way in our digestive tract, we're not allowing that fat soluble vitamins to be absorbed, proteins and fats. So they're really malnourished. So they can check labs to see what kind of vitamin levels we have, right? Or don't have, or they have. Okay. I think I'm gonna go through and skip that video and let you guys watch it so we can keep talking. Respiratory findings. So cough, again, we're talking about mucus, increased mucus, thick mucus. Intercostal retractions, use of accessory muscles, so it looks like RSV, right? Now, barrel chest on these kids, because this is chronic, right? So they can have, because of that thick mucus, they get more of that ear trapping. They look like a little man. My little guy that in my daycare kind of had that barrel chest going on. Plus, he also had the toddler belly with a barrel chest. Made him look a little awkward with really skinny little arms, but that's his disease process too. That's made him cute too. Barrel chest deformity, digital clubbing cyanosis, a little COPD man. That's kind of how we look. I hope that's not offensive to anybody. I use humor to kind of cope with things. Declining tolerance for exercise, so increased oxygen demand. So activity intolerance as evidenced by on exertion. Okay. So complications highlighted here is pneumothorax, right? Because of all that air trapping, you can have burst alveoli too. All that pressure buildup, creating a pneumothorax. So that's something in some of our older kids that we're watching for. Non-tuberculosis, mycobacterial infections, so they're more prone to getting infections. Their immune system is affected. Hemoptysis, what's that? Coughing up blood. So with the backup in fluid and how things are working and not functioning, you can see that pulmonary hypertension, and that's where you see some of that hemoptysis. Okay. So yes, GI mess. So we're going to keep talking about that, but moving on, GI findings. Meconium ileus I mentioned, sometimes the first sign that you see. Malnourishment, failure to thrive. So we have admitted kids for failure to thrive. They just don't eat, they're losing weight, or they go into a checkup, and then, or they're having some other complications going on that get them admitted, and then we do some testing and we find out that it's cystic fibrosis. We don't always have this meconium ileus. Sometimes it's found out a little bit more into the toddler years, but this malnourishment is going to be what catches them. So if we didn't have meconium ileus, we're going to see malnourishment and failure to thrive, delayed growth, distended abdomen, a little bit more than your average toddler. And that could be because of that backup, a lot of that bloating, enlarging of the colon as things are trying to get through. Let's see, vitamin deficiency. So A, D, E, and K are your fat-soluble vitamins, right? Pancreatic insufficiency. So there's mucus in your pancreas, and if we're blocking the pancreas off with all that mucus, we're not getting those enzymes through to the digestive tract. So this results in that steatorrhea, so really oily, shiny stools that are really foul smelling. Intussusception, we talked about that last week, is one of the findings you can have with this. Rectal prolapse, reflux, and gastroparesis. What's gastroparesis? Say again? Delayed emptying, can empty your stomach, right? Okay? So yes, it's primarily a GI disorder, but it affects our lungs so much so that's where most of our complications are. Endocrine and reproductive findings, we talked a little bit about that briefly. Decreased insulin production too, right? So that's called cystic fibrosis related diabetes. So delayed sexual development, absence or irregular menstruation, viscous or thick cervical mucus, decreased or absent sperm. So sweat, tears, and saliva have a high level of sodium and chloride. Okay, so that's identifying those are some of the complications, and that's it in a nutshell. When it comes to treatment, we've got some nebulizer treatments, so what we're trying to do is make these secretions easier to produce. That's our goal. We want to get it out of there because we want to be able to exchange gas. So we've got pulmazine as a nebulizer, right? Pretty much the only reason we give pulmazine is for cystic fibrosis. So if you have a patient who's cystic fibrosis, they're going to have this medication. Okay. We can do hypertonic saline. It works better for these guys than it does for RSV folks in helping to mobilize those secretions and get them out of there. And albuterol also. Pulmazine is going to be more of a daily nebulizer, then the rest are more as needed. Antibiotics, so they're on a lot of antibiotics. Preventative, because of all the secretions that are pooling and laying around that are not getting produced, so they're at risk for getting all kinds of respiratory infections. So we do have to worry about resistance, right? So if they've been on a lot of antibiotics, they might be resistant, which is also why they tend to have more infections. Oxygen therapy, right, as needed. Sometimes they go through these cycles where they're needing oxygen and not, so, or the prolonged they get, the sicker they get, the more often they need it. Okay, and then there's these CTFR modulators and ibuprofen that are helping. This is why we're starting to see some of them live a little bit longer. So back in the 60s and 70s, they pretty much did, their median life expectancy was about age 8. Now it's 37. My friend is 49. And she does not have a lung transplant yet. Do you know somebody?
Yeah, my husband's best friend passed away last year at 42. He had 3 lung transplants and a kidney transplant.
3 lung transplants and a kidney transplant, age 42, passed away last year. Wow, see that's a good fight, yes?
Yeah, he was a fighter.
Wow. That's a tough one. So some more treatment, the goal being airway clearance, right? So we're gonna have scheduled CPT, chest physical therapy. This says airway clearance therapy, CPT, chest PT. Same thing, so the handcuffing, we have these flutter valve devices, like in the picture in the lower left. And then there's the vests, the lower right picture. He's just chilling on his phone, got his little vest, little shake and bake, we call it sometimes. Although they're not baking. But you've seen those vests probably in the hospital, right? They put them on and then they leave them out and they leave them in the bed underneath them where they can get bed sores. That's a mess. But this postural positioning here is super helpful in getting movement of those secretions. So, I've even had like my kid in the daycare just kind of in my lap, just hanging upside down a little bit, and we make it a game and we play. I miss him. So we've got a little bit of a Trendelenburg going on here to help bring those secretions up, right? It's exhausting to try to work that every day, your whole life. And so this is scheduled like Q4. It's part of their schedule every day is CPT, right? Which is why he's just chilling on his phone, getting things done. And we've got the cup. Have you seen these little hand percussors? Yeah, NICU maybe, yeah. So diet therapy. So GI management. We have to get nutrition on these folks. So they're gonna need high calorie, high fat, high protein. They're gonna need vitamin replacement, A, D, E, and K, right? So, and pancreatic enzyme replacement as well, too, is that the other is? Pancreolipase enzyme preparations, enteric coating, so they're usually capsules. So they're pretty big, hard to swallow for a kid, right? But we can open up the capsules and we can put the sprinkles over food. We want to put it in something that's not high in fat, right? Usually applesauce. Put it in something a little acidic, because as soon as it hits the fat, it starts breaking it down, right? So it's not gonna work where it needs to. So we need to give it a different vehicle, and we wanna give it about 30 minutes before they eat, or right before. About 30 minutes, gets it in place, gets it ready to go, so that you then have enzymes to help digest the food that they do eat. So we're trying to help bulk up their stools too. They're gonna have laxative because of those mucus plugs to help keep things moving along so we don't cause obstruction. Many times, like these kids or adults might have their own tube feeding because it's so hard to get the calories in them. So they might have some oral feedings, but they may also have supplemental tube feedings that they do as well. And that's really just because of how much they have to eat. It's so much they have to drink and fill their stomach with that they bypass and they have a jejunum tube and they'll just go right into their small intestine and start absorbing. So endocrine management. So we're gonna watch for the diabetes. Insulin's their only treatment on that. If they do develop cystic fibrosis related diabetes. Bone health. When you're thinking about, malabsorption of those vitamins, and we're not absorbing vitamin D, right? Which helps us with calcium and bone development. So we need to monitor that. And growth hormone. So we can give human growth hormone. So lots of support, lots of education. There are support groups, a lot of people with cystic fibrosis join, because this is getting in the way of their life, right? And their day is consumed with trying to get the calories in, getting your CPT in, getting in doctor's appointments, and trying to live your life, right? And these are kids too, so you imagine how well that goes over once they hit the teenage years. So normalization of activities, peer involvement in activity, that's why those support groups are great, because even kids I know that have diabetes love those diabetes camps, or these cystic fibrosis camps, that be around other kids just like them that understand what they're going through. That really helps them. Meeting those emotional needs, coping, caregiver support, encouraging an independent, active child. If you take care of somebody in the hospital with cystic fibrosis, child or adult, especially one who is not really young, they're gonna have things their way. They're used to being in the hospital. They might seem like a demanding type patient. We need to be patient with them and ask them what works for them, what's their comfort level. Sometimes they want to schedule their meds. They don't like the hospital schedule and they might want it on their time. And that's okay. If that's what they've been doing at home, we can reschedule as long as it fits within the orders. We want to make it patient-centered and let them have some control over their life. So that's kind of what it's about, especially in those late teen, early 20 years. When you're in the hospital that much, you don't have control. Your life has to stop so you can be there. So if we can give some of that control back to them and their decisions while they're in the hospital with what we can compromise on, that's going to be huge. And I bring that up because that seems to be an issue for pretty much every patient with cystic fibrosis in the hospital or anybody with a chronic illness. So it's important to kind of try to let's help them with some decision making so that they feel like it's a team effort with them, right? They feel like the whole world's against them. They're in the hospital day in and day out, right? And you're in there telling them, well, no, the hospital, we're going to give it at 9 o'clock. They have no control over any of that. All right, so we need to keep educating about diet, ways to increase the calories, proper medication, safety, CPT, compliance with all of those things. Immunizations, protection, right? Because they're more vulnerable to infections. And of course, genetic counseling is in there too. So, that is a quick cystic fibrosis. Questions on that? Maybe right at 3 o'clock. You guys need another break?
Yes.
Okay, 10-minute break. We'll come back and do a fluid electrode.